My name is Leah Bauer. I'm a psychiatrist. I'm the medical director for the Midcoast Hospital-based behavioral health services, including the MaineMOM program out here. Christine, you want to introduce yourself before I start?
Sure. I'm Christine Wyman. I'm a clinical social worker, and I am the clinical director, or the clinic director for the Addiction Resource Center locations in Brunswick and Damariscotta.
Great. So we're going to be talking about contingency management, which is a form of treatment for stimulant use disorder and a program that we're piloting out here in Brunswick and Damariscotta that will be spreading to other locations in the Maine health system later this fall and hopefully beyond that as time goes on, because it's certainly a strategy that has a strong evidence base and robust effects for treatment of stimulant use disorder, which we are seeing more and more of. You can go ahead. So we'll be talking a little bit about what CM is and what we're doing, and see what questions you all have. So the problem we're seeing in Maine, certainly with methamphetamine and cocaine use, has been really increasing dramatically in recent years. And these substances, which are often combined with heroin or fentanyl, are often, part of lethal overdoses. In 2022, 62% of the lethal overdoses in Maine involved cocaine or methamphetamine. And the vast majority of those were, fentanyl was like the implicated in the death, but these substances were present as well. And we're just seeing many, many more folks using these substances than in the past. You can go ahead. And the only effective treatment we have for stimulant use disorder is contingency management, which is a behavioral treatment. There aren't any FDA approved medications for it that have been shown consistently to help. It's really this behavioral strategy, which is fair. It's really quite simple. It's essentially the use of incentives to motivate behavioral change. So often, what that looks like is patients coming into the office, and if they produce a urine that's negative for stimulants, they receive money, often in the form of a gift card. That's what we're doing, at least, and then that kind of positive reinforcement for abstinence grows and helps kind of rewire the brain, is the thinking. Go ahead. So there's a lot of really great data behind CM. I'll refer to contingency management as CM for simplicity probably here. It really has a ton of randomized controlled trials to back it up. And the vast majority of those trials show a significant positive effect in terms of abstinence from meth and engagement in treatment. There's been a lot of meta-analyses conducted that have all showed robust efficacy with effect sizes that are really moderate in range, with a G value of 0.54. And to kind of put that into perspective, many meta-analyses for antidepressant trials that for depression have significantly smaller effect sizes, like 0.3 typically. So CM really works better for stimulant use disorders than antidepressants do for depression. It's kind of puts it into a little bit of perspective there. And so generally, studies show that CM patients are about 3 times more likely to be abstinent by the end of the study, and with treatment retention rates around 60%. Go ahead. However, one might ask, what happens after the study ends? So you provide an incentive for somebody for 12 or 16 or 24 weeks or however long to come in and show that they're abstaining. What's going to happen when you remove that incentive? Are they just going to go back to using? Meta-analyses have shown that CM patients are more likely than comparison subjects to be abstinent on average 24 weeks after the CM trial ends. And there's kind of this like dose-dependent relationship between the length of active treatment and how long it works after, as well as like the strength of the incentive. So the higher the incentives, the more likely the treatment is to be effective and to kind of stay effective for folks. Go ahead. And in terms of like cost effectiveness, the the kind of cost is right there on the surface. You're you can show how much money people are earning through gift cards, and it can add up. What we're doing for our program is we're using a $599 limit, which might feel like a lot, to an individual. But it's much half the cost of a typical ambulance ride. So if you're saving a patient a ride in an ambulance and a visit to the ER, you've already, saved 3 times as much money as you would have spent. Or if the person ends up going to prison, immediately it becomes very cost effective. So, the idea, there aren't good studies yet, to my knowledge, that really show that you're saving money by doing this, but it clearly makes intuitive sense that we're, of course, saving lives most importantly, but also it's certainly worth the cost, which is much less than it's much less than a year's worth of buprenorphine. It really isn't that much in the grand scheme of things. Go ahead. So if CM is so great, why isn't everybody doing it? There's a lot of reasons. It seems like a simple concept, but in practice, it's really complex to implement for lots of reasons that we've walked through over the past couple of years as a program. And then there's also like a lot of knowledge deficits out there about how well it works and what it is. It kind of causes people to kind of recoil a little bit when you just explain the concept to them. It just feels kind of counterintuitive to folks who are outside of the field. A big barrier is lack of sufficient funding for incentives. Christine will get into some of that in a little bit about the kind of federal limits, which are really way too low and don't provide an incentive that is actually incentivizing. And then kind of misperceptions from the general public that this is, you're bribing people, you're paying people not to use drugs. Shouldn't they just be not using drugs anyway? And a lot of those comments are kind of rooted in more stigma than science, and the regulatory obstacles, which kind of lead partially because of the funding, that it gets in the regulations get in the way of sufficient funding, but there's also other concerns around kickbacks and things like that we'll get into. And so people get nervous about launching programs and worry about an additional liability they may incur. Go ahead. But despite this, the road is being paved as we speak around the country to really mainstream CM. A big program is out in California. They have a statewide program where they have dozens of sites around the whole state where they're doing kind of to the model CM, the same model that we're using. Our program is very much modeled after theirs. Other states around the country, the VA was a big pioneer in CM. They kind of get around some of the regulations because folks earn kind of money for the store that's right there on the campus at the canteen. And so it's a little bit different. And other states are kind of going through regulatory processes to break through some of the barriers and really fund true blue CM programs rather than kind of chintzy little ones that offer incentives that aren't really meaningful and don't really work.
And so I'm going to talk about some of the regulatory considerations or kind of some of the things to consider or work through if implementing a CM program. So one of the challenges is that you cannot use federal dollars to pay for the incentives, at least if they're not more than $75 per year. And that's not enough at all. Research demonstrates that patients who are able to earn at least $500 in the program have significantly better results. And so many programs who are able to implement CM choose a cap of $599. The reason why they choose this is because more money is better when implementing CM as it relates to the incentives. However, they want to stay below the taxable limit. And so if you're above the $500, that research has shown to be effective, but below the taxable limit of $600, that is really the sweet spot. And that is where we have chosen to have our CM limit. And so the big hurdle is that federal funding, is not really able to be used for the incentives. However, there's no restrictions on non-federal funding. And of note, other aspects of contingency management are billable. For example, we do submit, we put in charges for the urine drug screens that are done. Or if a physician or APP has met with a client and has outlined that they need to follow up with nursing for a specific reason, that nurse visit may be billable. The counseling, if there is counseling, may be billable. And so there are other parts of the model that may be billable. It's just the incentive piece is so hard. Next slide. So one thing that certainly came up for us in our process was the question of, isn't it a kickback? And the Office of the Inspector General recognizes the importance of contingency management and has observed that the federal government has funded many of the studies for it. And they have put forth guidance as it relates to guidelines and guardrails for CM. And that as long as your program meets conditions for a safe harbor, that it would be okay. For some of that is the key is that the incentive is for the UDS result only. It's not about attending treatment. It is specifically for the result of the UDS. Some states have applied for and been granted special waivers, these 1115 waivers, which allow for exceptions to the $75 limit for federal funding. I believe California is one of these states, and the purpose of that waiver is to allow for testing new or existing ways to deliver or pay for healthcare that aren't normally allowed with Medicaid. And the hope is that by us doing this with our pilot program, that the state of Maine will take this path too. Next slide. So in our program, what happens is we will have patients who are identified as having a stimulant use disorder, either at the point of intake or maybe they're involved in some other treatment here and they're identified as having a stimulant use disorder. They are staff talk to them about participating in the program and explain what it means. If the client agrees, then they would come in twice a week. We do Monday and Thursday, but another option may be Tuesday and Friday. They come in twice a week to provide a urine drug screen that provides an immediate result. And if it is negative for stimulants, then they are eligible for the incentive. We use software put out by a company who does specifically this work for contingency management that allows them to increase the value of their incentive over time if they have negative, UDS is negative for stimulants. That gives them an immediate, kind of like a gift card. The client receives the voucher on either their phone or a printout. And if the client chooses, they could participate in a group that teaches recovery skills. We're careful to not tie the group to CM. It's more that it happens to happen at the same time. And if they choose to participate, they certainly can, but there is no requirement to participate. After 12 weeks, the client then starts coming once a week for CM, and they do that for another 12 weeks, and then they will have graduated. Next slide. And so kind of how we got here, we started talking about this more than 2 years ago at this point. And it was through the support of the Maine Health Innovation Center, which gave us the grant funding for the incentives, that we were really able to propel forward. And it was through our collaboration with the Department of Health and Human Services that they provided the money for us to use the software that we use for the incentives. And the Maine SUD learning community, or CCSME, they provide consultation with Dr. Richard Rawson, who is a national expert in contingency management. We meet with him and Spurwink monthly for calls. Our goal was to start small and then work up. We really tried to focus on going slowly and carefully versus just having this large open service. Our target population are individuals who have a confirmed stimulant use disorder, but are not prescribed stimulants for any reason. And it's open to new or existing patients, and they can also have an opioid use disorder. And our program, as Dr. Bauer said, is modeled after the California program. And we were trained on the software by the company and then finally launched this past summer. Next. So what you're seeing right here is a screenshot of the software. And the benefit to it is that it reduces the amount of manpower needed, or people power, and it also increases security. One of the challenges with CM that has more tangible on-site rewards is the risk of them effectively walking off. And so this keeps it more secure, and it does all of the accounting for you. You need minimal patient information for this website, and it does not need to communicate with your health record. And the patient comes in, you record the result of the UDS, and then it gives you the dollar amount earned. And as you can see, it titrates up each week, or alternatively, as you can see, if there is a positive result, it will go back down for one visit, I believe. And then you can see the incentives earned there. The incentives can be banked or immediately used. It is recommended, though, that they're immediately used to really kind of, yay, you did this, here's the reward. The vouchers also are restricted. They cannot be used on alcohol, tobacco, firearms, or cannabis, which for us was an important consideration. Next. This is some data for our currently enrolled patients. As you can see at the bottom, about a third are they're enrolled in MOUD. Nearly 3/4 are enrolled in some other treatment in our services other than CM. And as you can see, a majority are enrolled in IOP. A few are enrolled in outpatient counseling for substance use disorders. And then once again, you've got that third in MOUD. As it relates to how many urines are stimulant-free, 3/4 are stimulant-free, nearly 75%. And as you can see, there's the incentives earned so far. Next slide. And so as we look forward, we have developed a relationship with the comprehensive addiction medicine programs in Portland and Norway, and they will be launching their CM coming up. And we have, with them, secured funding to cover the incentives through 2026. Next slide.